Okay, I'd like to go ahead and start this meeting for today. This is the commission to look at the costs of special education as a result of SB 57. That's nobody sitting there. That's your shadow. So what I'd like to do is, before we go any further today, I'd like to just go around so everybody, we have some new folks here on our commission. And I'd like to start maybe with Rebecca over there. You could introduce yourself.
I'm Rebecca Fredette. I'm the State Director of Special Education.
I'm Dwayne Ford. I'm a business administrator in the Bow and Dunbarton School District, so SAU 67, and was appointed by the commissioner.
I'm Dr. Jennifer Dolliff. I'm representing NHA SEA as a special ed administrator, and I'm an administrator in the Brookline School District. Oh, sorry, I've got this backwards.
Didn't have it ready.
Hi, Representative Megan Murray. I represent Amherst and Milford. I am also the clerk of this commission.
And I am Dick Ames. I'm representative from Jaffrey and Dublin, and I guess I'm vice chair
You are vice
of all
chair.
things.
Margaret Dry from Plainfield. I represent Sullivan District 7, which is Plainfield, Cornish, Newport, Unity, and Charlestown.
And I'm Rick Ladd. I chair, and I come from Haverhill, New Hampshire, and I also chair House Education Funding.
I'm Lisa Freeman. I'm the representative from Belknap District 8, which is Tilton, Samberton, and Belmont.
I'm Senator Victoria Sullivan. I represent Manchester wards 5, 6, 7, 8, 9, and the town of Litchfield.
Senator Keith Murphy, representing the people of Goffstown, Raymond, Hooksett, Candia, and Manchester. Thanks.
Wow, a lot of towns there. Well, welcome everybody, and we have this be the second meeting which we've had. There will be formal agendas each time we meet. We don't have one today, seeing we were really overwhelmed yesterday dealing with an issue dealing with one of our favorite towns along the Connecticut River, Claremont. And so with that, I'd like to just announce what we plan on doing today. At the top of the meeting, there are some sheets which I've handed out to you. The colored ones, there's 2 pages to the colored sheets. Does everybody have this sheet right here?
Yes, sir.
We do have some extras right here as well. I don't know how those showed up.
Sorry, yes, we got those.
Okay, so what they are, these were handed to me by Melissa White. She is over there at the Department of Education, works with Rebecca. And it shows where we are with special education in New Hampshire, and it just has some interesting information. The state's schools identify 19% of their students with disabilities. It varies by particular communities, and we have some that are up to 26%, and we have some that are lower, of course. And it gives you some helpful information. I'm not going to go into discussing that a whole lot right now, but it's just information for you. There's 2 sheets. There's the second sheet also shows you where we stand in terms of the reading on the NAEP and mathematics. That will be information we may use later on. The second set of materials which you received is a article which appeared in the Wall Street Journal just yesterday, and it's how autism cases rose as diagnosis morphed over time. And as we looked at this one of the 13 categories for IEPs, autism is one of those, and we went back to the year 2000, there was less than 400 kids identified with IEPs. Now it's approximately 10 times that. So it's up around 3,600 thereabouts. So it's something which is happening not just here in New Hampshire, but it's across our country. And that is also information that you may want to read and look at. We will be discussing that more thoroughly at the next meeting. What we had last week, and I will make sure all the members get some of the meeting we did last time, and we looked at, we had information which we looked at in terms of the costing of special education aid, which we used to call catastrophic aid, in the 50 states. There's materials handed out. and there's different formulas which are used. Some of the states have caps on how much money the state will spend on it. Some have where the state gets involved with catastrophic aid support instead of waiting to 3.5 times, 3.5x, in other words, about $70,000 spent on a student before they qualify for special education aid. They start earlier in the game. One of the things we did note is that it's very, very difficult. In fact, the information we have not been able to acquire is if we dropped our special education aid from in the formula from 3.5 times X to, let's say, 2.5 times X, or two times the average cost per pupil, and saying the average cost, roughing it out, be $20,000. Let's say it's down to $40,000 or $50,000. How many students would we then acquire and have to pay through the catastrophic or the special education aid account? We don't know. That information is not available to us. And that's something which we're trying to track and figure out how to get a hold of, because we know that the last go around when we appropriated dollars, the commissioner had approximately $34 million for catastrophic aid. We were shallow by another $16 million, and that was prorated down to the school districts at around 68%. And we did pass legislation where the proration can no longer go anything lower than 80%. However, we're not there yet, and there's much we have to do. So one of the areas we also had talked about, and we have two speakers here today, or two people that are willing to come forward and offer us some technical support and information about how they're handling the direct Medicaid support in the schools and how we're addressing that, even for those that are qualifying that are less than $70,000. How does Medicaid get involved? We have Henry Lippman from HHS. Henry is sitting over to my right, to the audience's left. And we have Dan Quarter. Dan, which committee are you from?
I'm actually from Boothby Therapy Service.
Okay, so you've been working with this issue of Medicaid for quite a while. And so we're going to have both folks come up and speak to us in terms of, you know, the issues that are associated with school districts, especially small school districts, applying for this. We heard that there are a number of school districts that may not be applying for the Medicaid money simply because it costs more in labor within that district than they're going to receive back from Medicaid. And so that is an issue which somehow we want to resolve. I'm not going to get into any more. Let's have first come up Henry Lippman from HHS, and then we can get Dan, you following. And what I'd like to do with this commission, if you have a question at any time, let's ask the question so we can not get past that and not get back to it. Is that okay with you, Henry? That's good. Okay. So, Henry, when you came to the Education Funding Committee a while back, we got into the issue of Medicaid, and you indicated to us we're leaving some money on the table.
That's my belief that some of what I hear from participating people, school officials that, and I think it was also shared by Commissioner of Education, had picked up some of the same feedback that, as you pointed out, accessing Medicaid funding is more complex than accessing special education. There's an intersection between Medicaid and the IDEA, and some of that sometimes we have different views on that in terms of people who work in Medicaid and IDEA, where that intersection kind of, where the overlap is and where it isn't. But Medicaid is essentially there to help deal with health issues that affect someone being able to learn. That's our role in school funding of services. It's the medical conditions that, or for disabled individuals, it could be a disability in terms of where, for example, like helping someone read versus helping someone toilet, right? They're two different, they fall in two different categories. In terms of what Medicaid allows, the history of it is, which is about to change in state fiscal year 27, is that the schools, if they build Medicaid, would get 50% of the fee schedule. The other 50% is the, if you will, the non-federal share that has to be paid to draw down. So it was actually operated as an in-kind methodology, meaning it was assumed that the 50% that wasn't paid was the school's contribution to covering the non-federal share. That methodology has been around for a long time, predates me. I've been the Medicaid director for, will be 8 years on November 1st. That methodology is being eliminated as an option effective the end of this state fiscal year at a federal level. And so we're converting to a different methodology. For those who may, who are legislators who sit at a county level, you may be familiar with a term called certified public expenditure. That's how we make up the difference between what Medicaid pays and what Medicare would allow in terms of costs. So in the school setting, we're going to be moving to a somewhat similar system using what we call certified public expenditures, as well as for the first time in New Hampshire Medicaid, allowing, which is allowed federally, to capture some of the overhead costs. So for example, there may be secretarial staff or other staff that are supporting the direct clinicians in like scheduling something, that some of those costs can be picked up as well. What's been the finding nationally in other states that have made this transition, Colorado being a good example of it, is that they saw a substantial increase in the amount of federal share that they could draw down. Because if you think about it this way, if say Medicaid was paying $15 an hour, $15 for a 15-minute unit of say physical therapy, right? In an hour you'd get $60. If the school has to pay $100 to hire that physical therapist, right, they're only getting half of the 60 when it's really costing them 70. So they're only getting 30% instead of really 50%. So in changing this methodology, they should be able to get 50% of their actual costs plus some overhead recovery that they've never had before. And so we went out and competed for a federal grant to help schools make that transition and to help the department set up the infrastructure for that to happen. That went through a competitive bid process. We involved a couple unusual of my time in making that selection. We involved some, at the recommendation from the Department of Education, a couple of individuals to actually sit on the procurement team that represented schools and we've been very happy with the vendor that we've been working with so far to help us set up that infrastructure. And there's a whole amount of training that we'll be doing. Plus, we're part of the procurement included setting up a help center to support schools in working through this new methodology that will be available like Monday through Friday, 8 to 4 type of schedule. And so we're trying to position this to help schools do better under Medicaid. It still adds a little bit of complexity, and it's always going to be more complex than accessing special education. Just by way of background, I had a mom who was a special education teacher for almost 40 years on the public school systems. So I have that kind of in the back of my mind in terms of, hearing what is involved in doing that. I'm here to suggest that, you want kids' needs to be met, but there may be ways that we're leaving federal money on the table if we're not fully capturing the health component of what, and that may vary by school district in terms of what that's happening. I've met with the Department of Education and suggested that the way we did some work before to kind of tease out where the intersection between IDA and Medicaid is to actually do some observation in settings that we could learn some more to help both the schools and the individual get the services that they need, but to also make sure that the state and local governments are not using general funds where federal funds are available. I also spent 9 terms as a city councilor in the tax cap community, so I have a feel for what, trying to work through a school budget situation is too. So, I think, I come here trying to say, what can we do to help finance special education where if there's a federal share available to the state and to the local communities, that's better than what we have today. We want to help.
Thank you very much. Are there questions right now from anybody? I have a couple questions here. Let me start out with one here. When you came to the last meeting that you went in the education funding, we had talked about the training needed for these communities to apply for this dollar. And you indicated to us, and we just very briefly touched it, that where could these communities, these SAUs or small school districts, get the support, seeing that they don't have the funding coming to them in their operating budgets to do this? You mentioned in Colorado, there's a possibility that they had a singular district where if a school district was trying to acquire Medicaid dollars, that they could get some support from that district, that singular district. The equivalent could maybe be the Department of Education.
So I think in Colorado, that my understanding is they formed a cooperative of which not every school district, but most school districts use to help them navigate to do Medicaid billing, and that they saw a substantial increase in what they were able to draw down federally. At the time when I was there, we had not received the grant award and we had not done the procurement. So those are two different things, and part of what we're, to try to set up a cooperative, we don't really, I don't see that there's a time frame to do that because the methodology we're using today is going to expire before I think anything gets to start. As the alternative, we are setting up a call center that will be staffed to field questions and calls, plus we'll be doing outreach to do training. In some sense, it hopefully that seeing what will be able to be pulled down may allow school districts to make investments sometimes to have a stronger staff member deal with Medicaid. There's a number of different factors that are different than just doing an invoice, right? You need to know a little bit about Medicaid billing in order to do it correctly. And so I think there are training opportunities, but there also may need to be some additional investment in that to make it work. And then, we have 172 or 174 school districts that are signed up to access Medicaid funding. What we have seen is that the Medicaid funding that's been accessed has gone down from pre-pandemic, and even since the pandemic was over with respect to what's being drawn down. Now, I think some of that is, there are compliance risks when you bill Medicaid, and that's why I think that it would be good to understand for once and for all really what amount of funding that may be being spent out of special education could be considered healthcare related, and to try to get that straight. I think this is the opportunity to get there, and I think it takes working together to find that exact point.
Representative Freeman?
Thank you, Mr. Chair, and thank you for coming in front of us. So I really do want to understand this correctly. So what you just said was that you have seen a decrease in claims since the pandemic, and during the pandemic, naturally, and since the pandemic. Is that correct?
Correct. We're down about 25% from where I think we were pre-pandemic.
May I have a follow-up?
Sure.
Thank you so much. So essentially, that means that there is money left on the table for these school districts that's not being accessed.
So I think this is where I think the gray area is in terms of if there is healthcare that they're accessing through special education that could be otherwise covered by Medicaid. then they're not necessarily leaving something on the table. They actually may be getting more because in the Medicaid world, you only get half of your cost.
Yes.
Not 100% of your cost.
Right.
And I'm not an expert on the school special ed funding and how that goes there, but my general understanding is it's not, after a certain cost, that's when the school districts get 100% of that funding, and I may not be 100% right on that, but I know that the formula works in a way that it's more favorable than Medicaid.
Thank you.
Yes, go ahead, Jennifer.
I just want to ask a clarifying question on the decrease in Medicaid revenues coming in. I think it predates COVID. I think, so the school districts are sort of at the mercy of the SMAs, the federal rules, and then also the state rules. So the state has changed the rules quite a bit prior to COVID, which I think has diminished the amount of revenues we've been able to bring back in. And I don't know if you can speak to that. I think one of the things I asked for was a longitudinal data on how much the state has brought in annually, going back 20 years. And then certainly what rules have changed over the last 10 years that have made it more challenging for districts to submit for Medicaid.
It's a very good question. I don't know that I can go back 20 years, but I can tell you kind of in 2018, 2019 period, that the expectation when you build Medicaid is that the setting should not differ. So one of the issues that fortunately the legislature dealt with just in the month of March when everything started to close down, just early that month, you may remember, Representative Ladd, Chairman, that there was a bill that was passed to deal with the fact that from a federal level, for example, a school psychologist who was certified by the Department of Education, under federal regulations, the party, you have to be a qualified treatment provider. And what that means, they may be as qualified as anyone else, but if they're not, the Office of Professional Licensure is where our professional qualifications are established. And so we had school psychologists, speech professionals. We had the dispensing of medication and supervision. I'm trying to remember all the things, but there were OTs, I think, were another area, that there were things that needed to be addressed to be compliantly accessing Medicaid funding. That was one set of issues. The second set of issues that added to the complexity was that even though you have an IEP plan, an individual education plan, or another healthcare plan, there needs to be orders by a qualified professional. And so historically, that may not have been part of the process in terms of when people were billing Medicaid, but it needs to be in terms to be compliantly drawing it. So those were, I think, two big issues that had the effect of reducing some of what was drawn down. During the continuous coverage Medicaid component of the public health emergency, there was also an enhanced federal match that was available to states, which we passed to school districts at, rather than being 50%, I think it was 60, at least 60%. So it was at least an increase in 10%. And then, so I think that part of the decline from the pandemic period is those things. But I think in terms of some districts mastered those changes better than others. And so where we were maybe doing pre those changes in 18-19 around 16 or $18 million, it fell below 15, fell below 12, and I think most recently just below 9. And so that I think there's a part of it that I think is being lifted up here, that and then when I talk about complexity, there are things related to accessing Medicaid funds that you have to be federally compliant with certain things, and they don't sound too complex, but executing them in a school environment can be complex. Like, how do you integrate the doctor in, or the physician assistant or nurse practitioner? You know, some schools were able to to do that more easily than others based on their community resources that were available. And then the quality of documentation is another thing that you have to have meet a certain standard of documentation too. So hopefully that helps.
It does. Could I
one
do a
follow-up?
quick follow-up question?
Well, go ahead.
Did you say that we're about 9 million or under 9 million?
About 9 million, I think. was the
So in
latest report.
2016, we were up to 30 million almost. We were at 27.9 million. So since 2016,
Yeah.
we've lost a considerable amount of funding. So I think really teasing out those issues that we're talking about makes sense.
Yeah, we were told 8.8 million
Yeah.
when you were here last
Yeah,
time,
so
and
that-
we're
I
leaving
think that-
half of it on the table.
So
Yeah,
we've
I-
lost more, close to $20 million annually for the last 5 or 6 years.
So how much of that is connected to those changes versus how much may be connected to those changes and being able to access funding that's different, that doesn't have those requirements, I think
Yeah.
I think we all need to understand better to make sure that the funding that's required of the state to fund these programs is the correct amount, right?
Yeah, agreed. Sorry.
Representative Ames, or who? Representative Murray or
We're fighting here. It sounds like you got things in hand and you're working on what's needed to be done to improve our capacity to access these funds, and all that's good. I don't hear anything that says we need different legislation to do this. But if I mishear, let me know. And then on a different line, are any of the federal changes that are coming at us for Medicaid affecting this area of work?
I think that where there could be some changes is if there are changes in eligibility in terms of the you have to be also Medicaid eligible to access Medicaid funds. But in terms of the HR 1 Big Beautiful Bill Act, some people call it OB3, that legislation per se doesn't really touch upon schools in a direct way. I think in HB2, our own state legislation, we returned to pre-pandemic eligibility rules, and we have seen some decline in enrollment on that. But those are partly federal flexibilities that expired at the end of this past June, and going back to what we call compatibility, that when we go out and look at someone's income or something like that, that there's a range in which we consider it's close enough to consider that that's eligible. And so that compatibility was narrowed down to sort of pre-pandemic levels. And New Hampshire is more conservative in that compatibility number historically. So we're at 10%. Most states are 20%. So.
Representative Murray, did you have?
Yes. Just to repeat, you said we currently are at 10% and other states are at 20.
I'd say in terms of the compatibility, when we go out and look and check something, if someone in their application says they're making $100 and we get information that says 110, we would accept that. We would accept the 100. Whereas during the pandemic, we would have looked at 120. Well, the other way, it can go the other way too. It could come back at 80. But a lot of states look at it at a 20% level.
And then one follow-up if I
Go
may.
ahead.
Thank you. So when you were going back and you were talking just in general about how some of the districts fared better than others in a post-pandemic world, can you speak to, when you said access to community resources, can you expand on that? Like, what did you mean?
So one example would be that the school was close to a medical provider who was willing to come into and participate with the school in providing orders. Some larger school districts were able to actually develop a contractual agreement to have that resource available, whereas others maybe had a small number of students and it didn't really make economic sense for them to do that. So they had to rely on a more goodwill perspective to get that information.
So when you're looking at these costs submitted by, let's say, Bow versus Colebrook. So obviously Bow has more students and maybe the efficiency of scale is a little better than it is up in Colebrook. But early on, you mentioned actual costs.
Right.
So the actual costs to Colebrook would be a whole lot more than perhaps what they would be in Bow. Because maybe transportation, all that. With this new system, are we looking at reimbursing these districts from Medicaid, that whatever percentage that might be, the actual cost, or is it going to be some standardized criteria that you're using?
So there'll be allowable costs that would be how you determine cost. That's standard across the country, if you will, in terms of what would be allowed. So if one school district had, because they did lower volume, they could actually get additional money than a district that has a lower cost. So volume, like in a nursing home, that the cost structure may be higher in a smaller county's nursing home than it is in a larger county's nursing home because of economies of scale. It does recognize that, but only for costs that would be typically allowable. That would be like the people who are providing the service and the people who are supporting the people providing the service. And, they may pay, if they pay 20% lower in that smaller district, the salaries of those people, that would offset some of the higher costs that they might otherwise be having. So I think it'd be fair to say that as long as the costs are reasonable, they would be recognized for those people who are directly providing the services and those that are supporting them directly.
So I'm still a little confused on this, and maybe Jennifer, you might be able to help me out in this. Because is there a range? For example, if it's a speech or occupational therapy or physical therapy, the service is going to be provided, but it's going to be, but for the same type of thing, issue. So it might cost more differently at different places.
Yeah, if you were acquiring a speech pathologist as an example, and you had a contract with them, and you were paying them X dollars per hour, right? That, let's say it was $100 per hour. Another school district entered a contract with the same person and decided to pay him $80 per hour. You don't recognize the $80 per hour contract at 100. You recognize it at 80.
Can I just give you an example of, and I hear what you're saying, and I'm in agreement with that. I think one of the examples of a change that took place that dramatically decreased the amount of Medicaid funding coming in was prior to the changes right before COVID, a speech pathologist could order speech pathology services, and that's how it's done in the medical field as well. The change that the state made was that a doctor had to order the speech pathology services, which doesn't really even happen in the medical world. So what happened was schools, some districts went out and actually developed contracts with physicians who were willing to order these services, right? But it turned out that was, you were getting less money in reimbursements and you were paying some physician to sign off on the medical services that were being provided. But I think that just gives you one example, meaning that prior to the many changes that were put in place by the state, the professionals were viewed as professionals, the occupational therapists, the speech pathologists, and so forth. Now there needs to be a physician or a physician's assistant or a nurse practitioner, I think. Go ahead, I'm sorry.
Yeah, I think I agree with you in part. So the standard is that they have to follow the professional licensure. So the law has been changed so that physical therapists can write orders for themselves for a certain amount of time, occupational therapists as well. The nurses, again, with the change that we made, was consistent with law that the medication administration, that the nurse could supervise that and it could be paid for. So there are things that went the other way too, that weren't allowable previously. But the state did not make changes that were otherwise not needed to be compliant federally, because at times, when you do things non-compliant, like we had a situation where we had to pay back $3 million to the federal government because the way things were set up on a service was incorrect and didn't meet compliance standards. So when you draw federal money, you have to draw it compliantly. And for professionals, they have to follow the Office of Professional Licensure standards. And, one of the things we did do is school psychologists, we were able to get them, they were not covered under state law. They were not covered by any board. And we worked with both the Board of Psychology and the Board of Psychologists to get them under that structure so that they would be able to be compliantly able to bill. The issue that then psychologists had was there was a cost for me to do that I didn't have before. But it's I can't change the federal requirements in the program.
Further questions?
I do.
Yes.
Another follow-up.
Representative Murray?
Thank you. So in speaking to, again, it sounds like there are a lot of complexities that districts have to be aware of. So when you're talking about this training component or the hotline that you're seeking to establish, what's there now? Is there something in place currently that allows folks to have an increased level of access to information, printouts, anything like that, that can help them currently?
Yes. And so there also is sort of like as a regulator, there's only so far we can go. One of the things we did do is we went to the New Hampshire Charitable Foundation, and they were provided probably over a course of several years, over $1.5 million of funding to support a consulting firm to provide a connection to the school to do what we couldn't do in Medicaid directly. But, we had webinars, we had developed with the Office of Professional Licensure a guidebook on navigating this. We did things. That being said, a Medicaid program, big dollars, but small staff. And so, I think to be fair to the schools, there's only so much we can do. With this grant money that we got, though, we can do a lot more. And, that's our intent.
And that's a competitive grant process, correct?
It was a national competitive grant process that we were able to access.
Question I've had before, I may have asked you last time, or I may have asked Rebecca Fredette this, is that if in fact I don't want to apply for Medicaid for a youngster that's in my school, because I'm going to just wait till I get to that $70,000 mark and start collecting general fund money or catastrophic aid, special education aid money, and I'm going to demonstrate to the folks at the department that through all these invoices and costs, I've got to that 70,000 mark, but some of that could have been reimbursed by Medicaid. I guess, is that checked to make sure that, rather than going the Medicaid route, I'm going to, as a district, I'm going to get reimbursed through the special education aid?
There isn't a mechanism that I'm aware of to look at that. And that's what I'm suggesting could come out of, and which I suggest that we could do without even legislation, is to work together with schools, with Department of Education to take a look at this, to kind of get a feel for, how much of this potentially could be done through Medicaid versus not. But Medicaid is specifically healthcare, not other things.
Representative Drag?
Thank you. Thank you for taking my question. I'm going to assume that some of the stuff, it's not retroactive. We couldn't go back now and look over anything and say we should have done this a different way.
I think that would be correct.
I mentioned it last time, we have certain states which we looked at, and some states are saying, don't bother coming to the state for money until you've accessed, or you can demonstrate that you've accessed other revenue sources, such as Medicaid. Is that a fair statement to put in statutory law?
So this is where IDA and Medicaid may not totally align. In Medicaid, even someone who is in prison still has the right to choose whether they want to accept Medicaid or not. So I think that's a federal issue in terms of, but I mean, I don't know how widespread that issue of is someone who qualifies for Medicaid because they might need it for services that are not in the school would turn it down. I don't think that's a huge issue, but not to say it never exists.
Well, that led to where I was wanting to go. If you have an IEP meeting and the parent says, I don't want Medicaid involved, I'm not checking the box off. So then when they get to that high cost where we have to start kicking in from special education aid, we will be in fact paying for something that we could have gotten money from Medicaid.
If for the healthcare component, yes.
Yes. Yeah, yes.
Thank you. And thank you for taking my question. I just want to clarify too, under IDEA law, an individual can say no thank you and please don't access my benefits. So when a district is exploring the access to Medicaid benefits, that's a conversation that happens some point at the early identification process, correct? I don't know much about IDEA other than where it sort of intersects with Medicaid, but I think probably one of your other speakers knows that better than I do.
So each year, the district has to ask the parents if they can access, they have to sign off and say that they can access their Medicaid, and they do it every year so that they can access it each year, but the parent can decline and say that they don't want it accessed.
Is that can I just ask, is that legislated?
It's federal law. Right?
No, I think that the federal law was one time. I think the states imposed an
the
annual.
last-
So
yeah, and-
so I think the point I'm trying to make is that the state is making it more and more challenging annually to bill for Medicaid. And I think, having a hotline where we can call people isn't going to help. I think people in the school districts understand the mechanisms for Medicaid. It's just so onerous and challenging. A good amount of the Medicaid funding, it requires the people on the front lines to continually record and submit paperwork when they've got kids that they're either, dealing with who are in crisis or providing services to. I think it's a lot more complex than we're describing.
May I follow up with another question? How does this intersect with FAPE law as well, then, when we talk about free and appropriate public education? Because an individual has the right to say, please don't access my benefits, but there should be no penalty to the individual for not accessing those benefits, right? Correct?
Correct. There's no penalty if they say that they don't want the district to access their benefits. They still need to provide the services that were determined by the IEP team.
Representative Dry?
Thank you. And let me just pick up with what you said, though. If you wanted to have the state demonstrate that they at least pursued that, I mean, you're not responsible for the answer that the parents give or whoever's responsible. But if the state can demonstrate that they have made the effort to do that, then it shouldn't be that hard.
I don't think any district would be reluctant to do that. I think they would all demonstrate, the efforts, certainly if it was going to help with submitting and receiving reimbursements.
That's what the state of Arkansas has done. They put in, and this is the language directly from it, the district must demonstrate and document that is fully sought this. Now, may not get it, and it doesn't limit it to just Medicaid. They're talking about private insurances as well. Yeah,
Yep, you said it, Alex. You stole my thunder, Ray.
I'm sorry.
You stole my thunder. And actually, if I may, I would like to ask the question of you, sir. Do you have a ratio of Medicaid reimbursement in the schools versus children who have conventional private insurance? And I think that's a conversation that we should be having, because if a child has an IEP and they have private insurance, that's not accessed at all. And the cost of the special ed still falls on the school district. So do you have a ratio for that, or a rough number of what that looks like?
I do not that I would sort of rely on, but I can give you sort of like a rule of thumb. Typically, commercial insurance is typically a couple times Medicare to 2.5 times Medicare.
Okay.
And Medicaid is typically at 80% of Medicare. So
Okay.
those would be some rough benchmarks, but I think part of and this is where you may need someone from the Department of Insurance in terms of how policies are written to cover services that are provided in schools. I think that there may be some variability in what policies are covered under different commercial plans.
Thank you.
Further questions or information needed from Henry Lippman? Well, thank you very much, Henry. We'll call Dan Quarter up next.
Sure. And if you need me again, I'm happy to come here. And I do want to support your work, and because I think it's important to meet students' needs and also to deal with the financial challenges we're having as a state.
Now, how's your database? Are you sharing communications with the department in terms of IT and all that? No.
We do a certain amount of things that we do provide to the district through eligibility, but that's basically as far as it goes. And the claims information, we don't share that back and forth.
Okay, thank you very much. Mr. Quarter, are you available? Could you just explain a little bit, what you do and
Yes, Dan Quarter is the name. I work for Boothby Therapy Services. We're a private company here in New Hampshire, and we employ, I think we're up over 200 people now who work in school districts, folks like speech pathologists, occupational therapists, physical therapists, school psychologists. And typically what happens is a school district will have a need for a part-time speech pathologist, and people want, say, a full-time job. So they'll come and actually work for us. We'll employ them. Then we'll contract them with a school district who, say, only has a part-time position. And then we can fill their time, maybe placing them in another district a couple of towns over. So at the end of the day, they have a full-time position. It may be kind of an itinerant thing, but we found that there's a real need for that kind of staffing support in schools. And we've grown over the past 6 or 7 years that I've worked at the company from around 80 practitioners to now, I think we're pushing 200 or a little more than that. So there's a great demand out there for speech pathologists and those other folks that I listed that keep us pretty busy. And because our folks deliver the types of services that Mr. Lippman has referred to in terms of what's covered under the Medicaid to Schools program, there naturally tends to be a conversation that we end up having with school districts around, well, how does this Medicaid program, how does the program work from a regulatory perspective? How does it intersect with special education and things like that?
are there specific questions which we may have for the program you have? Let's take a speech teacher that has a master's and their C's, and they are now contracted to work with my district, which is Haverhill, New Hampshire, which is probably another hour-and-a-half drive north from here. In working with that district, how do you come up with the cost, what you're going to build the district for the service, including the transportation to and from, the whole 9 yards? How's that arrived at? And then how much of that is eligible from Medicaid?
Well, the cost in terms of our relationship with the district is going to be market driven, if I can use that terminology. In other words, we have to compete for hiring. We try to hire the best people and pay them accordingly. And then that just trickles down to the contract that we have with the school district in terms of the cost to them. Then with respect to what is billed to Medicaid, that really kind of gets into the weeds of what I'll call the regulatory components of the program that, again, Mr. Lippman referred to in terms of the intersection between what we're doing in the realm of special education in terms of providing a free, appropriate public education, which of course can include related services, and what Medicaid actually allows for in terms of reimbursability. So to me, the real crux of the issue is for school districts to understand what are the parameters within the realm of special education particularly in the realm of related services, that also fit within the parameters of what Medicaid allows in terms of a reimbursable activity. So throughout the day, a speech pathologist isn't necessarily going to be doing something for the entire day that's covered under Medicaid to schools. It's only going to be covered when they're participating in the implementation of a child's IEP, when the nature of that intervention fits within the Medicaid definition of a medically necessary covered service, and all the rules of the program are met on top of that. Qualifications, orders, things like that Mr. Lippman has already referred to. So I think the challenge for districts is understanding in the big picture, what are their obligations under special ed law? And then distilling down to, in the implementation of the child's IEP, what component of the related services also fit within a certain amount of complexity that goes along with Medicaid reimbursement.
Who decides what is a medical issue versus what is an education issue that we have in the district? Is the district deciding that, or is your association deciding that?
Well, really, that's an operation, in my view, of statutory or regulatory definitions. In other words, we know what, say, speech is from a related service perspective, as that's defined under the IDEA. But then the district has to go beyond that and also understand what the Medicaid covered service definition of speech is. So that when they direct a speech pathologist, whether that speech pathologist is contracted or employed by the district, hey, when you're conducting this type of activity, this is what we want you to document for purposes of Medicaid reimbursement. So the district really has to be, I think, schooled in those statutory and regulatory definitions in order to properly direct their staff when they're implementing the child's IEP to make sure that what gets billed to Medicaid also fits within the Medicaid requirements.
So if you're going to a district which does not have, small district, 100 kids, and they don't have these specialists, but they have an IEP team and they go through the whole process identifying and identifying a disability for this child. So then your company gets involved and you have 200 well-trained folks that may go out. Are they the ones that are saying this is a Medicaid eligible component of his program? And, or no, is that still now the folks that are in the IEP team who don't have a background in the area?
Well, really, it's, in my view, the responsibility of the school district to understand all those parameters and then direct their staff accordingly. Now, what I end up doing is I'll go and work in a school district because they'll ask me to come and say, hey, can you talk about this program? And I'll say, sure. And then we try to work through all the different requirements of what the district should be aware of in terms of making those kinds of decisions to actually pull the trigger and seek Medicaid reimbursement.
Representative Freeman?
Thank you, Mr. Chair, and thank you for coming in front of us. So I'm listening to how you're unfolding this and where you believe the districts should be culpable and where your therapist should be culpable. But from what I understand, most of what is necessary and appropriate in an IEP is determined by assessments. So your therapist would be performing those assessments. Is that not correct?
Well, to the extent that they participate in the identification process of a child with a disability and then bring their assessment or their evaluation of the child to the team, the IEP team, ultimately the IEP team is going to make that decision. Now, certainly they're going to ask the opinion of, say, a speech pathologist, be they employed by us or by the district, and say, well, what do you think? And the speech pathologist, based upon their knowledge, training, background, experience, will opine to the team, so to speak, well, I think the child needs speech or doesn't need speech. But then I think it's pretty clear that ultimately it's the decision of the IEP team to make that decision whether or not the child is going to receive a related service like speech.
May I follow up on that?
Yes.
So from my knowledge of the IEP process, it's based on objective data and not subjective data. What I feel you just described was more subjective than objective. So you said what they feel like they should focus on if they feel that this child needs an IEP. So the reason why I'm asking this question largely is because, again, my limited knowledge of IEPs is that it is based on a need that the child presents based on assessments, and doesn't vary from that. And then the IEP and the therapist who performed the assessment sits down and draws up what's appropriate, what the long-term and short-term goals are. Am I correct in that?
Well, going back to what you said about objective versus subjective, I'll obviously defer to other people in the room who are better schooled in the IEP team process than I am.
Okay.
But my understanding is that special ed regulations, federal and state, lay out the standards for the different disability classifications that teams are supposed to consider. But ultimately, I think the IEP team is given latitude based upon the unique needs of a particular child as to A, what the disability classification is going to be, and B, what specialized instruction the child might need, and C, what related services the child might need. So again, I can be corrected here, but I think the IEP teams have a wide discretion, all within the boundaries of the requirements of the IDEA.
Thank you.
Rebecca Fredette.
So just to go back to the Medicaid question, if it's discussed in an IEP team meeting, that is not discussed at all, because the IEP process is that you take all those evaluations, you review those within that IEP team, and there is some latitude because every child is different and every child needs something different. So you would bring those pieces in, you would look at that data and you would say, in our professional opinion, we would say they need this for speech, they need this, but that Medicaid decision is not discussed in that meeting at all, because you can't make your decisions based off of whether you can get money for Medicaid. You have to make your decisions off of what the student needs and what their abilities are and what you need to provide for them. That Medicaid decision is going to come later when you're at the administrative level and you're going to say, okay, we have these kids that are getting these services that were determined by the IEP team. What of these services are we able to cover with Medicaid? And that's more of an administrative SAU type of decision. It should not be in your IEP team, and as far as I know, is not in your IEP team meeting at all, because you are working based off of the evaluations for that child and what that child needs.
So I want to follow up to that though. When I go to a heart specialist, I don't sit around the table with all the folks there, my wife and everybody else, and let's come to consensus of what Rick needs. I look to the specialist, the surgeon. What do I need? But let me go the next step then. So I understand the IEP. We don't talk dollars. We don't talk costs. That's absolutely, I understand that. But the need has to be addressed by that surgeon. The need has to be addressed by the speech pathologist that has the Cs, not necessarily a consensus of opinion. I understand how IEP, I've been in so many of those meetings, I can't even count them all if I had a million fingers. But I'm just really concerned that we're seeing an explosion in the costs of special education in this state. 1 out of every $4 we spend in public education, or in public ed, is special ed. And that is $1 billion a year. So I'm really wanting to make sure that we're doing, and I'm not questioning the staff, I'm not questioning, but I'm looking at these costs, which are just going beyond where I think we can continue to travel on that track. So how do we address this so that the need is really specific to that, what that professional is saying the need is?
So can I answer that question?
Sure.
We do. There's an LEA, which is a person at the IEP meeting, the administrator. We do look to the professionals to make that recommendation. It's not made by a team decision. There's not, folks can say, I think the child would benefit from more, but ultimately a speech pathologist is making the recommendation based on the assessment results as to what is needed in order to make that child make the gain they need to make. I do think that it would be productive of this team to talk about why some of the costs have gone up significantly. And I think, mentioning previously that, 5% increases in private schools annually has only occurred in the last 7 years. Prior to that, they were much smaller. I've worked in both Mass and New Hampshire, we've got some pretty hefty tuition bills for private schools because those compound when they increase so dramatically. So I think, 9 million in Medicaid funding is going to be helpful, but that's not going to be the answer that we're looking for. I think it's multifaceted.
Yeah.
Thank you.
Many components to this thing. Are there further questions of Dan Quarter? Yes, Representative Marie.
Yes, thank you so much. Thank you for taking my question. So I guess we were talking about, you were talking about sort of the market rate in determining your individuals who are traveling about through the state of New Hampshire, elsewhere in Massachusetts too, correct?
Right now, we're in New Hampshire and Maine.
Oh, Maine, thank you. And so within New Hampshire, are the individuals, is this a conversation with districts on a per contract basis for the cost of your services? Are they uniform in rate, or is it differing between?
No, it becomes an individual discussion with the district. And again, that's going to be based upon what's the degree of need that they have, because sometimes districts find themselves in a place of, they have an IEP in place, they have an obligation to provide the services, and they have no one to provide the services. And so sometimes they have to call us and say, look, we need somebody now. We need to get them in here because we're not providing the services that we're obligated to provide.
Thank you.
Well, everybody has this sheet right here. And you don't have one in front of you, do you, Dan?
I don't.
Yeah, why don't we just get that down or pass it around, or there, right there. I'm looking at there's a rectangular box in the bottom there. And I'm looking at the two graphs which go like this and like this. They torpedo. One torpedoes our population of the whole and the population which is got an IEP. And it's significantly growing. And when I talked with your boss the other day, Rebecca, I got the impression that we may be over-identifying. How do we address this issue?
Can I jump in while Dan ponders that? No.
Well,
I really don't feel qualified to answer that
Okay.
question. I'm sorry.
yeah. Well, Senator Sullivan, and then we'll go over to the other side here. Yeah.
And it's not a question for you, it's more for the whole committee. I met with a district recently that was talking to me about education advocates. And a superintendent and teacher were very concerned about these advocates that are coming out, and they're pushing and pushing. They're charging families an enormous cost to represent them for IEP meetings. And they're forcing IEP costs up because they're demanding children get services that they don't necessarily need, but they won't stop until they get them. Teachers are being bullied over this. It was the first I heard of it, but apparently it's a very big issue. One parent was told they had to give a $10,000 stipend to be able to be represented. And when we looked this up, they gave us a name of some of the advocates. The prices they're charging are insane. I'm definitely in the wrong business. So this is a real concern. And if we're seeing these costs be driven up, I think this is a factor we need to look into and see how much it's playing a part here.
Thank you.
I was just going to say, I think looking at this chart, the blue line is the total population of students, right?
Yes.
So that number has gone down because students are using alternative settings in part, right?
In part, but we're seeing that demographic decline significantly bottoming out since when I came on board here back in 2008.
Yep.
The population was over 210,000 kids at that time, K through 12. And the number of kids with IEPs was pretty equivalent to what we have right now in our population. If you look at how much we're funding, and I think our business manager would say for the state, we're right around 155,000, 160,000 kids, K-12.
So I think it would be helpful to know of that, there should be a third line then that students with IEPs, in alternative settings where the school still has to provide the services are included, because that red line encompasses all students with disabilities regardless of where they are, right?
Yes.
So I think just to give it a more accurate view, it would be interesting to see how many districts are providing special ed services in alternative settings.
And may I add to that? As well, when you add that statistic, should we also add the population decline over the past 10 years? Because I do remember a long time ago when I sat on a school board, we did see the projected numbers for declining population in the country, and specifically what was affected was the public school system. So could we also get those numbers as well, Rick?
I think, Rebecca, is it possible that you can give us the information regarding charter public schools, the number of students being served by the sending district, and the type of IEPs? I don't know if you can get down that deep, but at least can we get an aggregate of the total?
Sure. So any student with a disability that has an IEP is being serviced by their resident district
Yes.
in the charter schools. But I can get you the numbers of students who are in charter schools receiving special education. But it all goes back to if a student is going to the charter school in Northfield, but they live in Franklin, Franklin is still providing that special education service. They're still responsible for everything. So, and that's across the state. But yes, I can give you the numbers of kids who are in charter schools with IEPs.
So is the charter school number included in that blue line?
It's
That line says 166. When we look at the adequacy funding, it's lower than that. It's around 150, 162.
And the adequacy funding, follows kids in public schools. So then the kids in charter schools that are receiving special ed
Wait,
service,
I'm not sure if that's,
the only
it
the
comes from-
differentiated aid for special ed, I believe, goes elsewhere. But-
differentiated is non-targeted money, which goes right to the district.
Correct. But I think the districts get the differentiated special ed aid if they're providing special ed services in charter schools, but they don't get the adequacy. Correct.
Yeah. Yeah. Okay, so if we can get that information on the charters, this is a discussion to be had.
Yeah.
Yes, Representative Murray.
Thank you, Mr. Chair. I'm also curious to know if we can dive into the concept of funding gaps at the state and federal level. As far as initially we had talked a little bit about those funds at the first organizational meeting, just about, I think you were referencing something called 40% contribution from the federal government. So if that is something that we could take a look at and see, dig a little bit deeper and see.
IDEA is approximately $50 million, or 50, and then the differentiated aid is around $68 million. And then on the special education aid, it was 34, and I think we upped it to 50. Did Frank get it to 50?
It's 49. It's almost
okay,
50.
yeah.
Yep.
So I guess what I was saying.
But the
sorry.
federal government promised us 40% years and years and years ago.
I understand. And what I'm asking for is sort of a snapshot of where we are in comparison to maybe folks around the country. Are we still at 48%, or like what are
It never
others?
got to 40%.
Excuse me. You said, I apologize. You said you were. Did you just say? Somebody said 40.
I said 47 million for
Oh, sorry.
49 million for special education aid.
Yeah,
49.
yeah,
Thank you.
yeah.
Okay.
Senator Sullivan.
Thank you, sir. Rebecca, do we have any data as far as kids that are using like EFA programs or any other data of kids that are leaving public schools, going to private schools or alternative education that no longer need the IEPs when they leave?
We might be able to look into the special education information system and see who left, but we wouldn't be able to distinguish why they chose to leave special education. I believe the EFA programs would be able to tell you how many students access funds because they previously had an IEP or they've been determined to have a disabling condition. But the private school piece would be a little bit more difficult just because we don't. It doesn't say exited to Bishop Girton. It doesn't say that they went to a private school, but it may say that they exited and chose, parents refused special education.
I think it would be helpful to have the EFA, the amount of students that are taking funding for special education in the EFA programs.
Yeah. And how are the EFA IEP decisions made, are they made not by the sending district, is it by a medical doctor saying this child has an issue?
So there are two options. If a child was previously in a district and they had special education testing done and they were determined to have a disability, the parent can take those evaluations and determinations and bring them to submit for qualification for special education funds. If they do not have anything from a district that, because they previously had not done, there is an option to get what is called a disabling condition, and you can get a note from a medical doctor. I'm giving you a really watered down version. You can get a note from a medical doctor to say you have a qualifying condition, and then you would also be eligible to receive funds for that.
So the IEP is gone in 3 years' time. What happens then when it's no longer there? Can the doctor say, well, no, I'm going to give you that certificate and you're now...
So the doctor doesn't make a determination on the educational impact of the disability. So if a child is going to an EFA program and they find a physician that's willing to say they have a disabling condition, they have access. It's more challenging in the public schools and in charter schools to be eligible. I mean, it's pretty fluid. If you just find a physician that's willing to say a child has a condition that's, disabling, it doesn't have to have an educational impact. IDEA is based on the educational impact, meaning that we only identify kids with disabilities if it has an impact on their ability to benefit from education. So I think there's a real disparity in who's eligible and, which programs.
And can I ask a question?
Are there any other... Yes, go ahead.
And that determination doesn't have to be done every year, right? Under the EFA program?
I would have to double check. I'm not as familiar with the EFA program. I'm familiar with that language, but not the determination.
Yes, Representative Ames.
Yeah, I think just following up that it would be a good idea for us to try to get an estimate of both the number of kids that are in EFAs that are have been identified as with disabling conditions and who also came, maybe another slice that came to the EFA program with a continuing identification of disability or IEP eligible. And also the process that's followed. It would really be helpful, I think, to all of us. It's very murky. I've looked at it, and I don't think the numbers are.
So when we discuss the charters, we'll put the EFA program on that same meeting.
Yeah.
And we'll look at the whole 9 yards in terms of how IEPs or how special education services are delivered and how they are identified. So, Mr. Ford.
So back to, I know you're still sitting there, so, do you provide through this company any assistance through your staff of Medicaid actual logs and doing the billing? Because for us, I think we're big enough. We have 1,900 students in the SAU. We have staff that a portion of their time is dedicated to that, but there's a number of small SAUs, and certainly as the SAU numbers grown, that don't have that staff. So they either punt on Medicaid completely. Is that a service that you guys do or would do?
We don't offer what I'll call like a billing service, whereby we say, hey, here's a platform that interacts with the state's Medicaid management information system so you can submit your claims. We don't do that. There are companies out there that obviously offer those services. The conversation we have really kind of revolve around what I'll call the philosophy of the program. Are we operating within the boundaries of the Medicaid to Schools regulations when we deliver those IEP ordered services?
The last thing I would say on that is we use one of those services. We have our own staff who do it, but we also use a service to make sure that we're in compliance because I find the law is extraordinarily complex. We pay 8% of revenue received for that service. I've seen as high as 10. It's been lower than that in the past in my career. But we pay 8% right off the top. So any reimbursement we get from the state, we get a bill basically on the same day from the provider. That's 8% of the check that we received. So.
Yes, Representative Murray?
Thank you, Chairman Led. I guess my question then would be, based on Mr. Ford's question as well, do we, at the Department of Ed, look at the differences between those who have internal billers or folks that submit for billing versus external billing submissions?
So we don't take any of the billing at the Department of Education. It would go through Medicaid to schools.
Do you collect that data, Mr. Lippman, then? As far as whether or not
I actually can.
districts, oh, sorry, thank you.
There's a line on one of the DRA forms that we fill out, the finance forms. It's also on the revenue form. So Medicaid billing has its own line. So there would be a way, I would think, for DRA to tell you or anybody how many districts don't receive any aid. Now, that doesn't mean that they don't submit logs, but they don't get any aid. You know, I
I want to
started.
explain this a little bit more
Yeah.
because I'm totally unfamiliar with this.
Sure.
Yeah, you know, we're trying to find out kids which are not up to that $70,000 level
Yeah.
for the special education aid, but how many down below that have invoices been sent for Medicaid or Medicaid? Is that information data available through the DRA?
No, what I'm suggesting is there is a line on the, and I just did it today for one of my districts, is, you know, we're setting the tax rate. So you do a revenue form, it's due September 1. On that form, there is a line under the federal section for Medicaid reimbursement. What I am suggesting is there's probably a way for DRA to tell you, here are all the districts in the state, and here are all the districts that have on their revenue form some kind of Medicaid reimbursement. If I was going to tell you how many students we have in our SAU that we bill Medicaid on, that'd be an individual question you'd have to ask every single district, I think.
So you don't really have that, do you?
Well, I don't have the number of students.
Yeah.
But I think
Just have an aggregate.
But I think you would know, you'd have an idea what districts aren't getting revenue. And I am going to hypothesize that it's a number of small districts that aren't getting it. It's an extraordinary amount of time that it takes our staff to do it, from the practitioner themselves to actually doing the log to somebody's recording and putting that in. Then our staff at the SAU, one person in particular, is checking all of that, and then that's getting submitted. But we also, you know, take advantage of an outside provider who's doing orders. We had the ability to do that. There's a lot of doctors and medical people who live in Bow, so we have a nice relationship with one of them. But that was a big change. That's a cost that comes off the top of Medicaid reimbursement that we have. And I think, like a lot of districts, we had the most amount of reimbursement we had in the Medicaid program was pre-pandemic. The last 2 years, it's been lower than it's been in the past, but it's still 6 figures worth of reimbursement for us in Bow and about 30,000 in Dunbarton. So it's not an insignificant amount. It's worth the time for us to do it. But we have the staff to do it.
Yeah. Further questions from the group here? Dan, do you have anything further for us regarding your company and how it works? Do you do any online providing of services?
I'm sorry, do we what?
We have some districts, or very small districts, which can't afford. In my particular SAU, I have one town where they did this. They delivered speech services from California via the web. Do you provide that online capability?
Yes, we offer that to school districts.
Okay. Yes.
Dan, I just want to ask, as far as the rule changes and the impact on, do you have any thoughts on that you're willing to share? You sort of lived through everything as, you know, long-term special ed folks. Can you speak to the decreases in revenues or reimbursements? My apologies.
Well, I think, and it was mentioned earlier by Mr. Lippman, I think when we went through the changes to the regulations, and those were done because of the, I guess I'll say, the perception that we were out of compliance with certain federal requirements. And I'll say, I think reasonable minds can differ on some of those points, but I won't get into the splitting of hairs in that regard. But one of the challenges that's already been mentioned was, at least initially, districts were told that they had to use doctors to sign these orders as part of the process of ordering these covered services. And to the department's credit, they've kind of backed away from that over the years, in the past 5 years, because I think as we had conversations about it, there was a realization that it didn't just have to be a doctor. It could also be a licensed clinician operating within scope of practice. So now it becomes an issue of, well, what's allowable under scope of practice? And there have been various iterations around that. And so school districts have had to adapt to that. So when those kinds of things come up, it's kind of a shock to the system where, hey, we now have to go to all doctors signing orders. So districts try to come up with a system to do that. And that takes time and effort and cost because doctors aren't going to sign the orders for free. And then when the department, I think, kind of clarified its position on the issue and said, yes, you can use licensed clinicians, but they have to be operating within scope of practice. Now districts had to figure out, well, which scopes of practice allow for the signing of orders. And the department was very helpful in that they issued guidance after they got guidance from the Department of Office of Professional Licensure and Certification that kind of broke out the different areas whereby folks could sign orders within scope of practice. But all those things take time to be promulgated by the department, and then districts have to adjust to those different changes. And in the meantime, districts are motivated to try to stay within the boundaries of what they perceive are the restrictions on the program. They don't want to seek an order from someone who's not qualified to do so, because we're always concerned about that eventual knock on the door from an auditor. And auditors have their jobs to do, right, to make sure that the districts are staying within the boundaries of the program. But districts, I think, are pretty conservative in that they don't want to go outside of those boundaries. And they're not going to start using a licensed clinician, let's say, or a licensed practitioner until they're very sure that they've got it right, that that person can sign an order within scope of practice. So again, those things take time. And during that time, there are claims not being submitted because we don't have an order signed by a proper person, if I can put it that way. So that's one example of where I think different changes that may be driven by federal requirements are going to have an impact, a trickle-down effect, and cause a decrease in reimbursement until folks figure out, okay, where are we really on this? And are our folks qualified to perform these different functions? Signing orders being one example.
Yes.
Thanks, Chairman Ladd. So one of the things that I'm hearing you say, Mr. Carter, and also Mr. Ford, I'm curious to know whether or not you're talking about sort of making sure you get it right in these processes, and have you talked about sort of double, like, belt and suspenders approach to your process. And so my question is, how many districts may not have the same access to that, and those, you know, whether it's through school board budgets and securing those funding to hire somebody in-house versus going outside for a biller, or again, sort of double checking that information. I'd be curious to know if there is a disconnect there for folks to be able to access those services equitably among SAUs.
Are there any further questions from the committee here, Commission? Thank you very much, Mr. Corder.
Thank you.
And Henry?
I just have to get back for a meeting.
Okay, yeah, and I think several is, I know that Representative Ames has to get out of here by what, 2:30 or? Yeah. 2:40. 2:40. So we're right there. I think what we ought to do is sort of wrap this thing up but also discuss where are we going next? Now, there was a sheet that was handed out, and we're at the front side of submitting legislation for this coming year. And there is some legislation that I have submitted which replicates to a degree what Arkansas is doing. And they will not fund anything from the state until there's documentation that Medicaid has been sought. All they have to say is that, you know, the parent didn't want to release it, and then they can submit. But it also starts the support of special education aid a little bit earlier than we do at 3.5 times the average cost per pupil. But it also has a state cap on what the state, is going to spend on special education aid. Their cap is around, the state will spend no more, I believe it's about $110,000 per pupil.
Per year.
Per year. And then that's a lot of money, but in fact, we do know that we have some students which are costing us a whole lot more than that, as high over $500,000 per year. Just a few, like on a handful.
Well, the tuition in many of the placements is well over 100,000. So, I mean, there's more than a handful, I think, that would fall under the Arkansas cap.
Oh, yeah, yeah. But as far as that high level there, yeah, if you have a student that's receiving busing services and it has a paraprofessional, you're pretty close to that $70,000 mark. You're almost there. And that's probably a quick way of assessing how many kids are we going to have monies for in special education. We just look at that, we probably could figure it out. So, but the concern we have is that we do not have any data that goes anything, of those kids up from 0 to 70,000. And so if we back that formula off, what's that going to cost us in terms of having to appropriate from the state side for special education aid? That is the question. But we're going to have an answer to that, because these districts, when we've reimbursed pro rate to 68% or 80%, that leaves a lot of districts really deep in a hole. And that's difficult to deal with. So with that, the next meeting, let's try to get some information on the charter schools and the EFA programs. And I want to also start looking at some of these funding formulas that other states do have, as far as how special education aid might be handled and how we might even want to tweak our formula. But we need that information, that data. And it's very difficult to get a hold of. I don't think it's available. Yes.
I think I asked at the last meeting for some longitudinal data on how much, how much it used to be catastrophic aid, special ed aid, annually over the past 20 years, and then court-ordered placements annually over the last 20 years, and thank you. And the Medicaid to schools at the state level.
Like the episodes of, support or treatment and the catastrophic, can we get that going back so many years? I've seen those sheets before, how much we spent, and it's blowing up on us.
Yep, I can do that. An episode of treatment would only go back, I think it's 3 or 4 years.
Yeah, yeah.
Yeah, it's not, it's only new legislation.
$250,000, it's not a whole lot of money, is it?
Episode of treatment?
Yeah.
It is, because we pay for everything, there's no cap on episode of treatment. There is a cap on court-ordered placements where they have to pay 3 times the average cost per pupil,
Yeah.
but for episode of treatment, there is no cap.
Okay,
And so everything is paid through that fund
okay.
currently.
I'd like to get on some of the costing stuff as soon as possible here. Anything further? So-
Next meeting?
Oh,
Yeah, next meeting. Oh, he says, oh.
okay, let's try to do it.
So do we have an initial report or anything we have to?
Pardon me?
Do we have to put in any?
We have 1 year. This is a 1 year
What
deal.
about the November 1st interim report? Do we just have to say we've met, established, et cetera?
I just say we've met and we can write down a few things, but I think that's really intended for the next November, the end. This is only a 1 year commission.
No, I understand.
Yeah.
I just,
It does have a.
it does have a November 1st, 2025 deadline.
Yeah, we can put something very simple. It's not going to have a whole lot of meat in it.
We're working on it.
Okay,
I agree.
Okay, so-
Representative Ames, you're right on.
okay. And are you preparing that, Chairman?
Yeah, I'll work with our minutes and I'll work with Jennifer,
Okay.
In the rear there.
Okay.
So looking at the calendar for November,
Oh, we're into November. Okay,
yeah, well,
okay.
2
yeah,
weeks from now is still October.
yeah. Well, let's see, right now we're on the 15th. We could meet that last week if we can have that information. We should, but
In October?
I don't want to drive anywhere on Halloween.
well, Halloween is the 31st.
Yeah, that's Friday.
What about a Tuesday? Is that working for people mostly, or
Tuesday I
or
have,
Wednesdays?
we have 14 bills retained we're dealing with in that day.
Oh, right. Yes. Okay.
So
The 29th is that,
That's a
that
Wednesday.
Yes, sir.
is 29th open to everybody?
Wait a minute. Yeah, that looks
At 1 p.m.
AM or PM?
1 a.m.
good.
1 a.m. sounds
1
great.
AM?
A good compromise.
They
I'm
do those,
Novice.
they do that in Massachusetts, but we don't do it here.
I wouldn't know, I don't live in Massachusetts.
I could never tell.
Whatever, I haven't lived in Massachusetts in 30 years.
It sounds like you still live there.
30 years. 30 years.
Morning's better?
That's fine.
Are there any other meeting dates here that
Yeah,
compete with it?
isn't the SAU consolidation study committee?
No.
It's the 30th. SAU consolidation is on the 30th.
Sorry.
Then we will not interfere with their meeting if we have it in the morning.
Is 9 o'clock or 10 o'clock or 9:30, which is the best time?
9:30.
10 would give me some time to get here.
10?
9:30 or 10?
10
I'm
would
not
work for
available,
me.
but
We're
that's
talking about Wednesday or Thursday?
We're talking about the 29th at 10 o'clock.
Wednesday.
10 a.m.?
10, so,
Wednesday, October 29th at 10 a.m.
Yes.
Does that work for this side?
It doesn't work for me, but that's all right. We can.
Is there a better time on that day that works for you, or?
The afternoon would work. The morning doesn't work for me.
Well, 1 o'clock is what we've been meeting right now.
Is 1 o'clock okay for everybody?
I like 10 o'clock.
I think 1 p.m. work. Does that,
yeah, so I think it's good.
let's just stay consistent, 1 p.m.
I'm sorry, is that a consensus?
No.
I prefer 10 a.m. if you want to know the truth. I'm sure I'm not going to be a thorn in anybody's side, but we had decided on 10 and now we're back to 1.
So I can make that decision, or I can do a show of hands.
Make the decision, Rick, it's your committee, dear.
Okay, so how many people want to do it at 1 o'clock? We'll do it at 1 o'clock.
Very
We
good.
will do it.
Will or want to. Those are not the
Can.
same.
How many want to do it at all? One o'clock. How many people at 1 o'clock? How many people at 10 o'clock? Yeah, I'd like to do it at 10 too, because I get out of here. So we're going to do it at 10 o'clock on the 29th.
Thank you. Thank you.
We can always stream it if you want it.
No, I can't. I'm not available.
Okay.
Thank you.
Okay.
Okay, that's 10 a.m.
That's it. 10 o'clock on the 29th.
Got it.
Drive safely. We're adjourned.
You're not the boss of me.
No.
He actually is.
You know, I'll tell you something. I'm a Toronto Maple Leaf fan. And, you
Oh,
know,
I'm so sorry for you. I'm a Bruins